Hi everybody, my name is Heather Brummer. I am a nurse in West Wing 6, which is an acute spine and ortho rehab floor. I'm here today because I'm interested in getting your participation, hopefully garnering your participation in a new protocol called ERAS, which is Enhanced Recovery After Surgery. This is a protocol that's been used by multiple hospitals around the country, in the United States, and possibly even around the world. This program, ERAS, is designed to assist with recovery after surgery. It's somewhat of a fast-track program. It involves management at all stages, the pre, during, and post-op surgical stages. So this is, we begin by, kind of coming up with the reasons for wanting to implement this program, which are, as an acute spine and ortho post-op floor, we experience patients with a lot of pain. It's very consistent and it's very hard to control. So on our floor, we give a lot of different medications after surgery. We give large doses of opioids, narcotics, including Demerol, Percocet, oxycodone. We give some Valium. We have PCA pumps, and a lot of times patients who are on any of these, even PCA pumps with narcotics running in them, still need more and more pain medications. So of course, as nurses and healthcare professionals, we know that this is not healthy for patients and this is not safe for patients, because large doses of pain medications can of course lead to other complications, such as respiratory issues and patients not wanting to get out of bed right after surgery or the day after surgery, urinary retention, constipation, ileuses, a lot of different issues that can arise for patients when there are so many different types of pain medications. And all these things, of course, eventually lead to longer stays in the hospital, as well as decreased satisfaction and affects the HCAP scores and different effects that patients, who are not satisfied with the management of their pain, or think that they shouldn't be in any type of pain after surgery, or lessen pain. And there's only so many narcotics and so many medications that we can give before it begins to become a problem. So one of the things that we notice is that the patients who are more satisfied with their pain management tend to have better outcomes in general, because they wish to participate in physical therapy and they wish to get, they're able to get out of bed, they're able to start doing things for themselves and return to a more normal lifestyle more quickly than those patients who cannot. And of course, again, that leads to a little faster recovery and able to leave the hospital more easily and get on with their lives and experience the good benefits from these, surgical procedures that they've had. So the idea that a group of us have come up with is to utilize the ERAS protocol, ERAS, and this stands for Enhanced Recovery After Surgery Protocol. This is a protocol that's been used for quite a while now. It's used around the country in the United States. There's many, many studies on it documenting the positive effects of it. And among other things, what it does is allow patients to rely less on opioid medications and on these strong narcotics after surgery. The way that it does this is essentially by beginning in the preoperative phase. So instead of just going into surgery and hoping for the best afterwards, there's a team of nurses and perhaps nurse practitioners, doctors, physical therapists, anyone essentially involved in the healthcare process. And this team actually begins ahead of time by educating patients on the process of the surgery. So this may include determining what pain medications patients are on before procedures happen, as well as educating patients on the need to decrease the pain medications before surgery, so that they will have better outcomes and they will be able to more effectively manage their pain after the surgery. That is one aspect of the ERAS protocol. Another is that during surgery, the surgeons and doctors who are working on the patient participate in perhaps less pain management procedures during surgery. So they might use like an intrathecal type morphine or various types of pain blocks that may assist these patients to have better outcomes and less reliance and less strong opioids and strong narcotics. And then finally, after the procedure, the ERAS protocol recommends and states that patients can and should be able to manage pain using a combination of Tylenol and perhaps softer opioids like oxycodone, and 5 milligrams of oxycodone as opposed to a milligram of dilaudid push every 2 hours. And so, but in order for this to be achieved, all of this needs to be educated. The patient needs to be educated ahead of time as to kind of what to expect and the reasons for reducing their preoperative pain management, narcotics and whatnot. So we are a group of floor nurses, floor RNs, who are simply interested in making a change to our floor. And thus far what we have is several RNs who are interested in participating. We also have at least one nurse practitioner, one physical therapist, and we do have one doctor who is interested in this protocol. And we've looked at a lot of the different fast track programs and options, and ERAS seems to be the one that might do well and do best to implement in our personal, in our working environment. So if staff is in agreement, if administration is in agreement, our team, what we'll do is we'll go ahead and start to research our base data. And by that meaning, we need to know what percentage of patients that experience complications, on our floor due to the surgical process pain. So we need to know what type and what type of complications are being experienced on our floor. So for example, are we having X amount of ileus, of patients who develop an ileus due to postoperative narcotics? Are patients staying because they have urinary retention, or patients refusing to participate in the physical therapy process because they say that the pain is too intense and they can't get out of bed? So if once we have this research, we'll compile that research from our floor, and then if allowed, we would like to make a small pilot change, test of change to the floor. So for example, we have about 30 patients at any given time who are undergoing surgical procedures. Maybe, for example, we could choose 5 of those patients in order to use to implement this ERAS protocol. So let's assume that we do so, and then change is successful in our pilot program, which we presume it will be, because ERAS is a time-tested and study-backed program. So if this works, and if and when this works, what we would do is try to petition to make this change widespread across our floor, and we would like to see it implemented in all of our patients. And the reason, of course, is because we want better outcomes, and we want better scores, and we want more satisfaction among the patients and among the nursing staff, for that matter. So of course, the way that we evaluate all of this is to look at our baseline data and then compare it against the new data after implementing our program. And we want to see, have patient stays decreased, and have our patients using less narcotics and less opioid medications? Are patients able to get out of bed more easily? Do they seem more satisfied with their recovery and with their pain management overall? Now we know that there's any potential change has potential barriers. So the nurses who are part of this, our guess is that the change, that the potential barrier we might experience is from administration based on costs and financial aspects. And we intend to be able to show you that reducing costs in most or all other areas, after utilizing this protocol, after implementing this protocol, will offset any initial costs in order to implement the protocol. So things such as shorter stays, and of course rise in age caps leading to better reimbursement, and even less legal issues that could potentially be brought on when patients overdose on narcotics. So the other thing we may experience is some hesitance by the medical staff, by the medical team, and I think the way that this may best be addressed is to have at least one very well-respected medical doctor who is interested in the protocol and who would be interested in joining our team, and perhaps can help others to follow that situation. We don't believe there's really any ethical considerations because we're not breaking any rules here. ERAS is already an established protocol, and it demonstrates best practice. So essentially this is implementation of practice. This is not any type of research study or clinical trial. Those patients who are going to be involved in ERAS regardless will be made aware ahead of time, and they essentially consent regardless through their general consent for treatment. So thank you for listening, and if you are interested in joining our team, or if you would just like to learn more about this protocol and our intentions of hopefully implementing this practice on our floor, please contact the nursing staff at West Wing 6, and we will provide the information in the documents accompanying this video, email addresses, phone numbers, whatnot. We appreciate the attention, the time, and we look forward to being able to implement this practice as soon as possible and gain better results from our patients. Thank you.